Okay. Another class of antibiotics are the aminoglycosides. The aminoglycosides are bactericidal inhibitors of protein synthesis. Most commonly used agents include gentamicin, tobramycin, and amikacin. Okay? And so another confusing thing is that mycin is spelled two ways, right? It's like M-I-C-I-N and M-Y-C-I-N. And so again, there's lots of antibiotics with this mycin ending that are completely unrelated to each other. Okay? So that's another fun part of pharmacology. But it seems to be an antibiotic phenomenon. So gentamicin is probably the one that you have heard the most or have seen the most. But gentamicin is frequently used. It's a frequently used aminoglycoside. It has a very narrow spectrum, okay? But it's very effective against aerobic gram-negative bacilli. Okay? But the aminoglycosides carry risk for serious injury to the inner ear. It's very ototoxic and very hepatotoxic. Very nephrotoxic. Okay, so can cause kidney injury and also hearing loss. It is not absorbed by the GI tract, so it must be administered parenterally. Okay, it must be administered parenterally. Often intravenously. So adverse effects, as I mentioned, nephrotoxicity, ototoxicity, and we'll talk more about that ototoxicity because your risk for ototoxicity increases with what's called cumulative trough levels. Okay? Gentamicin and the aminoglycosides are one of these drugs where not only are we going to give them parenterally, but we're also going to measure peak and trough blood levels. Okay? And we want to see peak levels that are high enough to actually kill the infection. But we want to see trough levels at or near zero. Okay? We want to see peak levels that are high enough to kill the bacteria, right? So peak levels that'll be effective. But we basically want to see this drug get washed out. We want to see trough levels at or near zero. Okay? Because if trough levels are not at or near zero, day after day after day of treatment, that's the greatest predictor of ototoxicity and hearing loss. Okay? Specifically for the aminoglycosides. We don't usually do peak or trough with the other ones. But the aminoglycosides are really, we're giving you a little dose of poison and hoping it only kills the cells you don't want. Yes. This is going to be in-hospital treatment. Yes, absolutely. So hypersensitivity reactions are possible, meaning like allergic reactions. Aminoglycosides can also have a neuromuscular blockade effect. So if you're using aminoglycosides concurrently with other neuromuscular blockers or other general anesthetics, okay, or in patients who have myasthenia gravis, you run the risk of excessive paralysis. Okay? And of course, your greatest concern with excessive paralysis is respiratory depression. Okay? So you need to be very careful with that. Now, if the aminoglycoside level gets too high or there's presence of toxicity, you can actually, there is a treatment, IV treatment with a calcium salt like calcium gluconate, right, can help rapidly bring down gentamicin or the aminoglycoside because it will chelate with it. Okay. So other adverse reactions besides hypersensitivity, I think I already said that. The blood disorders. So changes in blood levels can also be found. Now, beneficial drug interactions, meaning that these are combining drugs that will add to the efficacy. Aminoglycosides can be combined with penicillins, cephalosporins, and vancomycin. Okay. But we do not mix them, okay? And we frequently do not give them at the same time. Okay. And then the adverse combinations of aminoglycoside, other drugs that are ototoxic or nephrotoxic or relaxed skeletal muscle, can exacerbate the adverse effects of aminoglycosides. Yes, ma'am. So you can give, someone can be prescribed an aminoglycoside and a penicillin, for example, but you, as the person who's actually going to administer the drug, you don't want to mix them, meaning that you hang two bags that then filter into a single line, right? And you want to separate when you give those drugs with time. Yeah. Okay, and then aminoglycosides, we're going to be very careful with the serum levels. So you're going to give us either a single large dose every day or 2 to 3 smaller doses. Okay? And then the serum levels are going to be monitored, meaning you're going to look for a peak and a trough. The trough, meaning the lowest plasma concentration, is evaluated just before the next dose. Okay? So let's say it's a once a day. Let's say you're giving gentamicin at 8 a.m. every day. Before you hang in your bag, you're going to look, the blood levels are going to be taken and evaluated. Okay? And what you want to see is a trough level that is at or near 0. Okay? Which, I mean, like logistically, that means that if the patient's supposed to get the drug, let's say at noon, which is the middle of your shift, you want to make sure that someone's come to take blood and do a blood evaluation before the next, right? Close enough to, but not too far ahead of the next dose. And then when that next dose is given, I believe it's a 30-minute wait before another blood sample is taken. Okay? And that's going to tell you the peak. So the peak levels must be high enough to kill the bacteria, but the trough level must be low enough to minimize toxicity. Yeah, 30 minutes. So samples for peak should be taken 30 minutes after giving an IM injection or completing a 30-minute IV infusion. Okay? Now, sampling for trough depends on the dosing schedule. With divided dosing, you take the sample just before the next dose. With a once a day, you draw a sample an hour before the next dose. Okay? But either way, it's very close to the next dose. And it should be very, very low, preferably near zero. Okay? Now, the reason why we do this peak and trough, okay, is obviously because this is a toxic drug, but also these aminoglycosides, their pharmacokinetics can actually vary from person to person. Okay? So the rate of absorption with an IM injection or the rate of elimination with an IV infusion can vary from person to person. So we want to make sure, no matter what the pharmacokinetics looks like in this particular person, that the peak is high enough to be effective and the trough is low enough to avoid toxicity. Okay? All right. So gentamicin are prototypic aminoglycoside used to treat serious infections caused by aerobic gram-negative bacilli. These are infections like Pseudomonas aeruginosa, E. coli, Klebsiella, Serratia, Proteus mirabilis. Adverse effects, as I mentioned, predominantly nephrotoxicity and ototoxicity. Hearing questions or? Okay. So, another class of antibiotics are the sulfonamides. Okay? The sulfonamides are a class of antibiotics that contain what's called a sulfa group. Okay? And sulfa groups are found in many different classes of drugs. Okay? We have sulfa drugs that are antibiotics. We have sulfa drugs that are included in the oral anti-diabetics. Okay? And one thing to keep in mind when we talk about sulfa drugs is that there are some people who have sulfa allergies. And sometimes these sulfa allergies are quite intense. They're anaphylactic reactions. So if a patient has ever reacted to any kind of sulfa drug, we tend to assume a high cross-allergenicity with other sulfa drugs. Okay. So if they've ever had a reaction to any kind of sulfa drug, we tend to avoid other sulfa drugs. Okay. And then not included in the sulfonamides, but another newly emerging category of antibiotics is trimethoprim. Okay? And trimethoprim, the reason why we talk about them with the sulfonamides is that they are frequently combined. Okay? Both are broad-spectrum antibiotics. They have very closely related mechanisms, and they suppress bacterial cell growth by inhibiting tetrahydrofolic acid, which is a derivative of folic acid or folate. Okay? So folate or folic acid is a cofactor or coenzyme in the production, in the replication of DNA. Okay? So it's needed for cell division. Folic acid, folate is necessary for cell division. Okay? And which is why, obviously, we emphasize folic acid for pregnant people, right? because to grow a whole new person, that's a lot of new cells. And folic acid deficiency is particularly bad in terms of central nervous system development. Okay? And so folic acid deficiencies increase congenital anomalies, including things like spina bifida or other neural tube defects. Okay? Now, with these drugs, the sulfonamides and trimethoprim, they are blocking folic acid, this derivative of folic acid, as a way of inhibiting bacterial cell growth and division. Okay? Which isn't a problem for a grown-up to take because this critical cell division is no longer really a major issue for you. Okay? So the sulfonamides, there are the first group of sulfonamides that were available were less effective and carried more toxicity than the ones that are available now. They inhibit the synthesis of folic acid, okay? And so mammalian cells don't manufacture their own folic acid. We actually take it in dietarily. And so mammalian cells are not as affected by these drugs as bacterial cells because they rely more on synthesis of folic acid. I think it's still avoided in pregnant women. I believe so. Yeah. The primary use with the sulfonamides is in urinary tract infections. Okay? So sulfonamides are frequently used for UTIs. There are other applications, Nocardiosis, chlamydial infections, and also conjugation therapy for toxoplasmosis, malaria, ulcerative colitis. Okay. So it has some other applications, but it's most frequently used to treat UTIs. Yeah. Sulfonamide adverse effects. We see hypersensitivity reactions, even as severe as that Steve Johnson syndrome, that necrotizing epidermal disease. Okay, it's very rare, but we do see it with the sulfonamides. Hematologic effects like hemolytic anemia, so the increased lysis of red blood cells leading to anemia. Kernicterus, I forgot what kernicterus is. Anybody remember what kernicterus is? That's what it is. That's right. Newborn jaundice, when bilirubin levels are high, okay, the bilirubin in the bloodstream can affect brain function, and that's what the kernicterus refers to. So sulfonamides, how that relates to sulfonamides is that it can increase the likelihood of bilirubin buildup, leading to bilirubin entering the brain. Adults, correct. That's right. It can lead to this adult form of kernicterus, yeah. Yes, ma'am. So kernicterus is when bilirubin levels are so elevated that they cross the blood-brain barrier and cause brain neurological dysfunction. You're welcome. Okay. And then renal damage from crystal urea, so increased crystal formation leading to injury to the kidneys. Okay. Drug interactions, the metabolism-related interactions, it can intensify effects of some drugs. So sulfonamides can increase levels of warfarin, phenytoin, sulfonylureas. The sulfonylureas are the anti-diabetic drugs that are also in that sulfa group. And then cross-hypersensitivity with other drugs like the thiazide diuretics, loop diuretics, and the sulfonylureas. Yes, sir. Right. I don't know off the top of my head. That's a really good question. So I do know methotrexate does also disrupt folate. But I don't know if they disrupt it in the same way. Yeah, that's a good question. Okay. So trimethoprim is an inhibitor of dihydrofolic folate reductase, the enzyme that converts dihydrofolic acid to its active form, tetrahydrofolic acid. And so it suppresses bacterial synthesis of DNA and RNA. Okay. It is used for the treatment of UTIs, both acute UTIs and what are called uncomplicated UTIs. Uncomplicated just means like your run-of-the-mill UTIs. Okay. Complicated UTIs are they're not really different than UTIs. Complicated UTIs are complications of other problems, like catheterization, okay? Like being immune compromised, okay? Like having diabetes. Okay? This drug can also treat them as well. Yes, ma'am. No, they're both used to treat UTIs. So the UTI, the drug of choice is really, so UTIs are usually caused by a particular set of organisms. In certain situations, it's caused by more unusual organisms, right? And so whether you choose sulfonamides versus trimethoprim really depends on how old you are, what your medical condition was, which increases the likelihood of one organism versus the other. Does that make sense? So the most common cause of UTIs is E. coli. Okay? And it's E. coli that is, how do I delicately put this, self-sourced. Okay? The most common cause of UTIs is poor hygiene and that 2 inch of space just not being enough, if you know what I mean. So the UTIs are also more common in females because they have shorter urethras, but there are other common organisms that cause UTIs, but like I said, in certain patient populations, you're more likely to have a UTI caused by an unusual organism. Like yeast is very rarely a cause of UTIs, but in patients who are immune compromised, for example, it's much more common. And so the choice of treatment is going to really depend on that. Okay, so E. coli, Proteus mirabilis, Klebsiella pneumoniae, Enterobacteria, coagulase negative staph. These are fairly common causes of UTI, and trimethoprim is very good at treating those. Okay. So adverse effects, we've got hematological effects, megablastic anemia, which is an abnormality of red blood cell production leading to anemia. Thrombocytopenia is this low platelets. Neutropenia is low neutrophils. It can also cause hyperkalemia, and it is not generally used in pregnancy and lactation. It's not completely contraindicated, but it is not recommended to be used in pregnancy and lactation. Animal studies have shown a teratogenic effect because of folate deficiency. Okay. Now, there is a combined drug that's becoming much more commonly used for UTIs called Trimethoprim sulfamethoxazole. This drug, TMP/SMZ, combines the sulfonamide with the trimethoprim. Okay? And basically, it is a better blocker of folic acid synthesis because it blocks it from two different directions. And it also expands the spectrum of organisms. Okay? So it's much more powerful than either drug alone. And so plasma drug levels the drug is given to reach a plasma drug level ratio of 1 to 20. Okay? So for every 1 unit of trimethoprim, you want 20 units of sulfamethoxazole. Okay? Therapeutic uses, including UTI, obviously, but also we can use it not usually as a first line, but as an alternative to treat things like otitis media or ear infections, bronchitis, shigellosis pneumonia caused by Cystiminus divroseci, pneumocystic pneumoniae. So both of those are more common in immune-compromised patients. Right? They tend to be opportunistic. Okay? So patients with HIV/AIDS and other GI infections. Adverse effects, nausea, vomiting, very common, rash, hyperkalemia, hypersensitivity reactions. So the adverse effects are going to be a combination of the two drugs. The blood disorders, the kernicterus, renal damage. All right. Yes, ma'am. Yes. Yeah. Yeah. So if you go back to like the first couple slides of this thing, it categorizes the drugs by their mechanism of action, and you'll see. No, it's okay. But you'll see them listed in that way. Yeah, absolutely. Yes. So that. Why would you remember that I showed you that? That was many slides ago. But that could be a nice way to kind of start thinking about them. Yeah. Yeah. Okay.